I want you to picture a scenario. And this isn't, hypothetical. It comes from a really gripping account on Kevin MD that was in our reading stack.
Right.
You're in a hospital room. There's a woman in the bed, and she's clutching her chest. She's gasping for air. Her eyes are wide, and she's desperately, desperately trying to speak. But the words, they aren't in English.
And to the nurse who's standing there trying to figure out what's going on, it just looks like anxiety. The patient is hyperventilating. She's frantic.
It looks like a classic panic attack.
Totally.
Right. But it isn't anxiety, it's a heart attack. And because she can't articulate that specific, crushing sensation she's feeling, and because the nurse can't decode the plea, there's a delay.
A huge delay.
A massive delay.
And in cardiac care, delay is damage. I mean, her son isn't there to translate, the interpreter line isn't connected yet, and all that time, precious minutes are just ticking away.
Muscle is dying.
Yeah.
Exactly. Now, in this story, they did eventually figure it out. She survived, but barely. And the author made a point that just really stuck with me. It was luck, not the system, that saved her.
And that's really what we're unpacking today, isn't it?
It is. We usually think of language barriers as, a customer service issue. Like, it's annoying if you can't get directions or something.
That is the common perception.
Yeah.
But the research we're looking at today, it frames it so differently. In healthcare, a language barrier isn't an inconvenience.
It's a full-blown medical emergency. Welcome back to the Deep Dive. Today, we are looking at a stack of research that suggests language barriers are a hidden epidemic in patient care.
We're talking about how they increase medical errors, delay treatment, and just break trust, especially in the high-stakes world of cardiac telemetry.
And this deep dive is brought to you by Whole Life Healthcare.
We're going to cover a lot of ground today. We really need to talk about the cognitive science behind why these errors happen, something the literature calls the translation bottleneck, and also why relying on, say, family members to translate is actually one of the most dangerous things you can do.
And sticking with our mission to not just admire the problem, but actually solve it, later on we're going to talk about some tools that can fix this, including the EKG Survival Kit we've linked in the description.
Yeah.
If you're working in this field, you'll want to grab that while it's affordable.
Yeah.
It has some really functional clinical tips to help with these exact barriers.
So let's start with the scale of this, because I think when people hear language barrier, they think it's a niche issue, a rare thing.
I definitely did. But then I looked at the census data and the Joint Commission reports in our source stack, and the numbers are just staggering. Do you know how many U.S. residents speak a language other than English at home?
It's somewhere around, 20% of the population?
It is 67.3 million people.
Wow. Which, to put that in perspective, that's basically the entire population of France.
The entire population of France living within the U.S.
Yeah.
Exactly. That's about 1 in 5 households.
So this isn't a once-a-month problem.
No, this is an every single shift problem. And the research shows that patients with limited English proficiency LEP, they have significantly worse outcomes. We're talking longer hospital stays, higher readmission rates.
And a much higher risk of what they call adverse events, like falls.
Right. And falls seem so unrelated to language at first.
Well, let's chew on that for a second.
Yeah.
Why falls? If you can't understand the instruction, do not get out of bed without help. Or if you don't know how to even ask the nurse to help you to the bathroom,
You're going to try to do it yourself.
you're going to try it yourself, and that is when the fall happens.
It's a cascade effect. But there was one statistic in the source material that it stopped me in my tracks. It was about physical harm.
Oh, I know the one you're talking about, the adverse event study.
Yes. The study found that language barriers cause detectable physical harm in 49% of patients.
Let's just pause on that. 49%. That is basically a coin flip. If you have a language barrier, there's a 50-50 chance you will suffer actual physical harm.
Not just emotional distress, but bodily harm. And moderate temporary harm in another 47% of cases.
But we aren't just talking about hurt feelings. We're talking medication errors, surgical delays, falls, real damage.
And that physical harm, it breeds a very specific kind of psychological harm, mistrust. The sources mentioned it develops towards telemetry techs and RNs specifically.
Which makes sense. If you feel like your provider doesn't get you or is just ignoring you because it's too hard to talk,
Yeah.
you stop trusting them with your life.
Which is the perfect transition to the core of what we want to discuss.
Telemetry.
Telemetry, because this is where the science of communication gets really interesting and really, really high stakes.
Okay, let's dig in. We all know the chaos of a telemetry floor.
Oh yeah, it's alarm fatigue central. You have phones ringing, monitors beeping, people shouting.
Yeah.
It's a high-noise, high-stress environment.
And in that environment, clear communication is the only thing keeping patients safe. One of the papers we looked at breaks down this phenomenon they call the translation bottleneck.
This was the aha moment for me.
Okay, so let's break it down. Imagine you're a native English speaker. You're a monitor tech. You look at a screen, you see this jagged sawtooth line.
Mm-hmm.
Your brain instantly maps that image to the words atrial flutter. It's seamless. It's a reflex.
A pattern recognition. You see it, you know it.
Right. But now imagine you're an ESL practitioner English as a second language. You see the jagged line. First, you have to recognize the pattern. Then you have to retrieve the medical name for it. Then you have to translate that concept into English. And finally, you have to articulate it.
So it's a multi-step cognitive chain reaction. It's not just one leap.
Exactly. And that chain creates what they call a micro delay or linguistic latency. It's not that the practitioner doesn't know what it is. It's that their brain's working memory is being taxed by the translation.
And in telemetry, we're not talking minutes here. We're talking seconds.
Milliseconds that add up. The research says a human can usually interpret an ECG in about, 20 to 28 seconds? But if you add that linguistic load, that translation bottleneck, it slows reaction time.
And here's the kicker.
It slows it down enough that it effectively neutralizes the advantage a human has over AI.
That is fascinating. So the brain is working so hard to translate the syntax that it actually pulls resources away from the clinical judgment.
Precisely. It's a reallocation of cognitive resources. And it's not just about speed, it's about accuracy. The source material highlights something called phonetic confusion.
Oh, this makes total sense, especially in a noisy room. Medical terms are so precise, but they can sound incredibly similar.
They do, and this is where the safety climate gets compromised. Let's just role-play this for a second. You're in a loud room. A phone line is crackling. I say atrial fibrillation. You say atrial flutter.
Fib versus flutter. Yeah, if you have a thick accent or if the connection is bad, those vowels could sound identical.
But what about the prefixes? Tachy means fast. Brady means slow.
Tachycardia versus bradycardia.
If you're an ESL speaker, or you're listening to one, and you miss that prefix tachy versus Brady, you are describing opposite conditions. One heart is racing, the other is stopping.
And the sources mention suffixes too, like regularly irregular versus irregularly irregular.
That's a tongue twister for native speakers.
Yeah.
But regularly irregular suggests a pattern, right? Like a no-bits block. Irregularly irregular suggests chaos, like AFib.
Now imagine trying to communicate that nuance over a phone line to a doctor who's in a rush while a monitor is beeping in your ear.
It feels like a setup for failure. And this leads right into that safety climate issue, hierarchy and silence.
This is critical. You can't talk about language without talking about power dynamics.
No, you can't. Often, ESL staff, maybe a monitor tech, might feel this power disadvantage. They see a rhythm change, they know it looks bad, but they hesitate to call the nurse or the doctor.
Because they're afraid of looking incompetent.
Or just afraid of being misunderstood, afraid of stumbling over the words and getting yelled at. So they wait, they watch, they double check.
And that hesitation is a silent error.
And in cardiac care, silence can be deadly.
It's heartbreaking. The skill is there, the intent is there, but the language gap just creates this paralysis.
And if we flip the perspective to the patient, that paralysis is there too.
You're talking about the button, the call light.
The lifeline.
Yeah.
There was this study we reviewed on nurses' perspectives about call lights, and it found a paradox. I actually want to ask you, if you were in a hospital in a foreign country, didn't speak the language, would you use the call light more or less?
I'd probably use it more, right? I'd be confused, scared, constantly asking for help.
That's what most people assume. But the data shows the opposite. LEP patients use call lights less frequently.
Wow, that's really sad. Why?
Fear and futility. They're afraid they won't be understood. Or they just physically don't know how to explain what they need. Imagine you're in chest pain, where you have to use the bathroom. But you know, pressing that button starts a conversation you can't have.
Someone's going to come in, ask, what do you need? And you won't be able to answer. So you just suffer in silence.
You suffer in silence. The study describes this burden mentality. Patients feel like they're burdening the system. They don't want to be the difficult patient.
There was that fascinating mixed method study on cardiovascular patients that broke them down into groups. Do you remember group 3?
Yes, group 3. That was a very distinct profile.
Describe them for us.
So these are patients who are socially isolated. They have unsupportive environments. And the study found they feel their health is actually worse than English speakers. not because their heart is worse, necessarily, but because they are healing in a total vacuum.
They can't communicate with anyone around them. They're completely alone in a crowded hospital.
Precisely. And that vacuum leads to real, tangible errors. Going back to that Kevin MD source, there was the example of a heart failure patient. Kept coming back to the hospital. Readmission after readmission.
Which is a huge metric for hospitals. They get penalized for that.
Right. And everyone was frustrated. Why isn't this patient compliant? It turned out the patient didn't understand the prescription. The bottle said, take 1 pill daily.
Which seems clear enough.
To us. But the patient interpreted daily as only on the days you feel symptoms.
Oh, wow. So they were treating a chronic condition like it was an acute headache.
Exactly. They were skipping days. Their heart failure got worse. They ended up back in the ER. A simple misunderstanding. Daily versus during symptoms.
So naturally, when people hear this, they think, well, we have a solution. The patient's son is here, or their daughter. Just get them to translate.
And that is the trap. The family trap. It is the most common false solution.
The sources are so clear on this. Relying on family members is dangerous. But I want to dig into why. Is it just about accuracy?
Accuracy is a huge part of it.
Yeah.
Your 12-year-old does not have the vocabulary for myocardial infarction.
Right.
But it's deeper. There are massive ethical and emotional issues. Like in that case from the source material, the 28-year-old with knee pain.
Oh, yeah, the patient spoke Urdu.
Yes. The doctor used mixed simple English and Urdu and relied on the family to fill in the gaps. It led to a complete misdiagnosis because the nuance of how the fall happened got lost in that game of telephone.
But also, think about the emotional burden on the family member.
Exactly. Family members often edit bad news. If the doctor says, this looks like a malignancy, the son might translate that to his mother as, he sees a shadow. They try to protect the patient.
But in doing so, they deny the patient informed consent.
And confidentiality goes right out the window.
Yeah.
You might not want to discuss your reproductive history in front of your child. Relying on family destroys patient privacy.
But there's another false solution hospitals fall for, the bilingual staff myth. Oh, Nurse Sarah speaks Spanish, just grab her.
This is a pet peeve of mine. It sounds like a great resource, right?
Oh, yeah.
And it can be if they are validated.
Validated. What does that mean?
Well, think about kitchen Spanish. You might be able to order food at a restaurant. That does not mean, the Spanish word for anticoagulation therapy or ventricular tachycardia.
That's a really good point. I can order a beer in a couple of languages, but I definitely can't explain a surgical consent form.
Exactly. And the sources say employers just rely on self-reported fluency. Oh, you speak Spanish? Great. Go talk to the patient in 302. But without actually testing their medical vocabulary, you're just introducing errors.
So we've established the problem is huge. The easy fixes are dangerous. The stakes are life and death. So what do we actually do? How do we fix this?
The good news is there are actionable solutions.
Yeah.
But they require a shift in thinking. It's not about buying more iPads. It's about structural communication changes.
One of the first tools the sources mention is SBR.
SBR, Situation Background Assessment Recommendation.
Now, most of our listeners in healthcare know SBR, but the research suggests it plays a special role for ESL staff.
Right. Don't think of SBR just as a checklist. Think of it as a linguistic scaffold. A scaffold? Yes. If you're that ESL telemetry tech and you're panicking because you see a bad rhythm, your brain is scrambling to form sentences. SBR gives you pre-built structure. You just fill in the blanks.
Situation: patient is in VTACH. Background: history of bypass. Assessment: rhythm is unstable. Recommendation: need a response team now.
Exactly. It bypasses that translation bottleneck. It reduces the cognitive load so the brain can focus on the medical facts, not the sentence structure.
And then you pair that with closed-loop communication.
The gold standard. They use this in aviation, the military. It's the only way to catch those phonetic errors we talked about.
How does it work in practice?
The sender gives an order, give 1 milligram of epinephrine. The receiver repeats it back verbatim. I understand, giving 1 milligram of epinephrine.
And the sender confirms. That is correct. It seems so simple, but it catches the error before it happens.
Right. If I thought you said flutter, but you said fibrillation, that repeat back catches it immediately. It forces a pause.
The sources also talk a lot about visuals. I love this because visuals are a universal language.
They are. The brain processes visuals 60,000 times faster than text.
60,000 times. That's insane.
It's basically instant. So in telemetry, we're seeing a move toward AI dashboards that use visual hierarchies. Red flashing icons, color codes.
You don't need to translate emergency. A red flashing light means emergency in every language.
And for the patient, Simple communication boards. We shouldn't underestimate low tech. A laminated board with pictures. A picture of a toilet, a glass of water, a diagram of the body where they can point to the pain.
It gives them agency back. It solves that burden mentality. They don't have to find the words, they just point.
Exactly. And then for the complex stuff, you have teleinterpretation services like Convey Connect. The key stat there was the speed.
Connection time under 10 seconds.
That changes the game. If you can get a video interpreter on an iPad in 10 seconds, you have no excuse to use the patient's son. You have a professional right there, virtually.
There was one more concept in the solutions section that I found really profound. Cultural brokering.
This is where we move beyond just words. An interpreter, acting as a cultural broker, explains why a patient might be acting a certain way.
Can you give an example?
Sure. Let's say a patient keeps taking their telemetry leads off their chest. The nurse keeps putting them back on. The nurse might just write non-compliant patient in the chart.
Thinking the patient is just being difficult.
Right, but a cultural broker might explain she's removing them because of modesty. In her culture, having these wires under her gown with a male tech in the room is unacceptable. Or maybe she believes the wires are letting spirits into her body.
Oh, wow. That changes everything.
Once you know the why, you can solve it. Maybe you offer a female technician, or you explain the tech differently. But without that cultural context, you just have a difficult patient and a frustrated nurse.
It's amazing how much of this just comes down to prioritizing communication as a hard medical tool, not a soft skill.
That's the takeaway. We see oxygen as essential. Antibiotics as essential. If the pharmacy is out of antibiotics, we panic. But if we don't have an interpreter, we just shrug and say, we'll make do. That mindset has to change.
Which brings us back to something we mentioned at the top. Navigating these barriers takes tools. You can't just wing it.
Right. Hope is not a strategy.
That's why we want to remind you about the EKG Survival Kit. The link is in the description. It's not just about reading rhythms, it's about functional clinical tips to bridge these very gaps.
Absolutely. It's a great resource to have when things get chaotic.
So as we wrap up, I want to leave listeners with a thought from our pre-show chat. You made a comparison to the cath lab that I think really drives this home.
Yeah. You know, in cardiology, we have this metric, door-to-balloon time. If a patient comes in with a blocked artery, a STEMI, we move heaven and earth to get them to a cath lab. We have teens on standby. We measure down to the minute.
Because time is muscle. Every minute that artery is blocked, the heart dies a little.
Exactly. But here's the question. If we can get a patient to a cath lab in minutes because their artery is blocked, why can't we get them an interpreter in minutes because their communication is blocked?
The technology is there. We have the iPads, the services.
The gap isn't technology, it's priority. We have to decide that understanding the patient is just as important as treating the patient. Because if they can't explain their symptoms or don't understand their meds, the outcome is just as bad.
That is a powerful place to leave it. We cannot rely on luck. Clear communication is as essential as oxygen.
Absolutely.
Thank you for tuning into this deep dive. Check the show notes for the resources we mentioned, specifically the EKG Survival Kit. Let's make our hospitals safer for everyone, regardless of what language they speak. And as always,
Keep digging deep.